It is absolutely clear now, with hindsight, that the disease was spiralling out of control. But to what extent was that possibility foreseen, planned for, and guarded against? How ready were the public health structures to deal with this possibility? The reality was that the United Kingdom government announced it would stop all community testing for COVID-19 and focus instead on testing people in hospitals and protecting health workers as it moved from the contain phase to the delay phase. So it's clear that the system had not adequately foreseen and prepared for the need for mass testing in the event of a non-influenza pandemic. For a flu pandemic, of course, you're most likely to show symptoms. You know you have a bug. You go home, possibly to bed, and you try not to pass it on, and tests aren't needed. On the 13th of March, the then Welsh Minister for Health and Social Services, Vaughan Getting, MS, announced the suspension of a number of NHS services to allow for services and beds to be reallocated and for staff to be redeployed and retrained in priority areas. On the 16th of March, the number of deaths in the United Kingdom rose to 55, with 1,543 confirmed cases. But the likely number of infected cases was probably over 10,000. There was no antiviral medicine and no national pandemic flu service to prescribe it, for the simple reason that COVID-19 was not an influenza virus. The United Kingdom government commenced daily press conferences. The Prime Minister announced anyone with a high temperature or a new and continuous cough should stay at home for 14 days and not go out even to buy food or essentials. The country was told to stop non-essential contact with others and to stop all unnecessary travel, to start working from home where they possibly could, and to avoid pubs, clubs, theatres and other such social venues. The same day, the Department for Business, Energy and Industrial Strategy issued a statement calling for businesses to support it by supplying ventilators and ventilator components across the United Kingdom. My lady, you have directed that we ask to what extent had the system envisaged and prepared for the need for mass provision of personal protective equipment. On the 17th of March, the Chancellor announced £330 billion worth of government-backed loans and £20 billion in tax cuts and grants. The Foreign and Commonwealth Office advised against all non-essential international travel. France imposed a nationwide lockdown. The then First Minister of Scotland, Nicola Sturgeon, MSP, made a statement to the Scottish Parliament setting out the stringent steps that were required to be taken. The NHS England Chief Executive, then Sir Simon Stevens, and the NHS England Chief Operating Officer directed the NHS in England to take measures to redirect staff and resources to free up inpatient and critical care capacity. These included the postponement of all non-urgent elective operations, the urgent discharge of all hospital inpatients who were medically fit to leave, and the block buying of capacity in independent hospitals. Was this need for surge capacity something that had been adequately prepared for? On Wednesday, the 18th of March, the then Secretary of State for Education, Sir Gavin Williamson, MP, announced the closure for the end of that week of schools other than for children of critical workers and vulnerable children. Exams and assessments were later cancelled. The Scottish First Minister, the Welsh Minister for Education, Kirsty Williams, MS, and the First and Deputy First Ministers for Northern Ireland, Baroness Arlene Foster, MLA, and Michelle O'Neill, MLA, made similar announcements. But how developed were those plans for school closures? On the 19th of March, the Department of Health and Social Security and the Ministry of Housing, Communities and Local Government provided further details of how a £5 billion support package would be given to local authorities. The Defence Secretary, Ben Wallace MP, announced that up to 20,000 MOD and service personnel would be placed on standby to support public services, including by way of driving oxygen tankers around the United Kingdom. On Friday, the 20th of March, the Chancellor announced the coronavirus job retention scheme and payments of grants backdated to the 1st of March of up to 80% of furloughed workers' salaries. My lady, cafes, pubs and restaurants were requested to be closed from that night, and nightclubs, theatres, gyms and leisure centres as soon as they reasonably can. In separate televised addresses, the then First Minister of Scotland and the First Minister of Wales, Mark Drakeford, MS, made similar appeals. At 5 p.m. on that Sunday, Public Health England figures showed that there were 5,683 cases of COVID in the United Kingdom and 281 deaths. At that time, the data referred only to deaths in hospitals and didn't even include deaths in the community, in care homes or in hospices. There'd been a rise of 48 deaths since the previous day, 37 in England, 7 in Wales, 3 in Scotland and 1 in Northern Ireland. The weekly provisional figures for deaths registered in England and Wales with COVID-19 as an underlying or contributory cause, calculated by the Office for National Statistics, was 103 for the week ending the 20th of March and 539 for the week ending the 27th of March. On Monday, the 23rd of March, we will recall that the Prime Minister announced severe restrictions on the entirety of the United Kingdom in what became known as the first national lockdown. On the 24th of March, the Senedd, the Welsh Parliament, agreed to a legislative consent motion on the coronavirus bill. On the 25th of March, the Coronavirus Act was passed by the United Kingdom Parliament and received royal assent. It had passed through all stages in the House of Commons procedure in a single day. And then on the 26th of March, the lockdown regulations were introduced. The Health Protection Coronavirus Restrictions England regulations were introduced by way of a statutory instrument made by the Secretary of State, Matt Hancock, Member of Parliament, using emergency powers available to him under the Public Health Control of Disease Act, 1984. And the regulations came into effect the moment that they were made at 1 p.m. on the same day. Analogous coronavirus restrictions regulations were made in Scotland and Wales by the Scottish ministers and the Welsh ministers. On the 28th of March, health protection coronavirus restrictions regulations were also made by the Department of Health in Northern Ireland. I mention, my lady, the various regulatory structures because one of the work streams that had been progressed in the years leading up to the pandemic was one of working on a pandemic bill, a draft pandemic bill, to cover for the eventuality of a pandemic striking the United Kingdom. But in the reality, the lockdown regulations that were made in England were made under a 1984 Act, the Public Health Control of Diseases Act, in Scotland under the Coronavirus Act, and in Northern Ireland under a 1967 piece of legislation. That day, the 26th of March, the daily death toll went up by 115. The pandemic had the country in its grip. Almost every area of public life across all 4 nations, including education, work, travel, the majority of public services and family life were adversely affected. The hospitality, retail, travel and tourism, arts and culture, and the sport and leisure sectors effectively ceased. Even places of worship closed. My lady, as you know, for very many, what they had to deal with went far beyond the curtailment of their normal lives and involved bereavement, serious illness, deprivation, mental illness, exposure to violence at home, terrible financial loss, loneliness, and many other forms of suffering. Health and social care workers, the police and the emergency services, transport workers, teachers, and other key workers continued, however, in their places of work, and they put their own lives on the line in terms of their safety. The months and years that followed, we all recall, saw death and illness on an unprecedented scale. But I don't need to set out, even in outline, the events that followed. The lifting of the first lockdown, the further lockdowns, the local restrictions, the gradual differences of approach between the United Kingdom and the devolved administrations, and finally the route out of the pandemic afforded the gift of vaccines. That is because, for the purposes of this module, the state of preparedness must be measured against the reality of when the pandemic first struck, January 2020. It's my solemn duty to record that government figures state that up to the 12th of May 2023 in England, there have been 192,231 deaths where COVID-19 was recorded on the death certificate. In Scotland, the figure is 17,603. In Wales, it is 11,848. And in Northern Ireland, 5,295, making a total across the United Kingdom of 226,977 lives. My lady, by the measure of excess deaths or excess mortality, that is to say the number of deaths from all causes, over and above what would be expected under normal conditions had the pandemic not occurred, so capturing not only confirmed deaths, but also COVID-19 deaths that were not correctly diagnosed or reported, as well as other causes that are attributable to the pandemic, the figures are likely to be higher still. Research reveals that mortality rates were significantly higher among people with pre-existing conditions, such as dementia and Alzheimer's disease, heart disease, high blood pressure and diabetes. Shockingly, mortality was 2.6 times higher in the most deprived than the least deprived tenth of areas. People from some ethnic minority groups had a significantly higher risk of being infected by COVID-19 and also from dying from it. COVID-19 mortality during the pandemic was highest in people from the Bangladeshi, Pakistani and Black Caribbean communities. And mortality rates were higher among people with a self-reported disability or a learning disability. And so the big question for Module 1 is, to what extent were those terrible outcomes either foreseen or capable of mitigation? My lady, the pandemic has had profound financial and economic consequences. It's put national health systems under enormous and continuing pressure. The impact on the healthcare systems, its operations, its waiting lists, and on elective care has been immense. Millions of patients have either not sought or received treatment, and the backlog has now reached historic levels. Jobs and businesses have been destroyed, and livelihoods were taken away. The pandemic disrupted the education of children and young people, put children at risk, and has left us with an enduring concern that the pandemic furthered disparities in attainment and development. The pandemic impacted the most disadvantaged communities in society all the more, both in terms of the consequences of getting the virus and in terms of the steps taken to combat the virus. Societal damage in terms of the exacerbation of inequalities and the denial of access to opportunity has been widespread. Its impact will be felt for decades to come. My lady, the emergence of this natural disaster could not have been avoided. But the key issue is whether that impact that I have described was inevitable. Were those terrible consequences inexorable, or were they avoidable or capable of mitigation? The starting point for your inquiry is that whilst we may not know the moment that this virus came into existence, or how exactly it made its way into the human race, we do know that the possibility of a pandemic had been foretold and thought about. Indeed, it had long been assessed by planners that there was a significant risk of a non-influenza pandemic and an even greater risk of a flu pandemic. Such risks were assessed and thought about and planned for and prepared for and written about by the departments, bodies, agencies, services, responders and personnel who make up the United Kingdom's emergency preparedness, resilience and response structures, the the EPRR structure, the first major acronym to which it's my unhappy duty to refer in an area infested by acronyms. But fundamentally, in relation to significant aspects of the COVID-19 pandemic, we were taken by surprise. Huge, urgent, and complex policy decisions were required to be taken in relation to shielding, employment support, managing disruption to schools, borders, lockdowns, and non-pharmaceutical interventions, restrictions, social restrictions. And equally importantly, the profoundly unequal impact of the pandemic on the vulnerable and the marginalized. Few of those areas were anticipated, let alone considered in detail. My lady, no amount of foresight or planning can guarantee that a country will not make mistakes when a disease strikes. But that does not mean that we should not strive to be as ready as we sensibly can be. No country can be perfectly prepared, but it can certainly be underprepared. And so it is to the adequacy and sufficiency of those structures, the plans, the steps taken to prepare, and the degree to which the country was resilient, that is to say, able to respond and bounce back, that this first phase of the COVID inquiry turns its attention. Module 1 will ask, were the right EPRR structures in place, the right procedures, the right plans? Was the system of central devolved regional and local government response available and ready to go? Did civil contingency planners think carefully enough about the risks of a pandemic and how they could best prepare for the crises which might develop from those risks? Module 1 will look at whether the EPRR system was effective and practical, that the bodies and structures that populate it were fit for purpose and not duplicative or obsolete. We will ask whether the system was designed to work well under pressure, whether it gave responders, nationally and locally, the proper tools to respond with. We want to know whether the policy documents and planning guidance were useful and not tarnished with bureaucracy or prescriptive overmanagement or jargon. Most of the evidence over the next 6 weeks will be concerned with those issues. My lady, standing back, there can, however, be no proper scrutiny of the pandemic planning, with which, of course, you are primarily concerned, without a simultaneous, detailed examination of the actual civil emergency structures upon which pandemic planning rests, because pandemic planning is, of course, just a feature of the wider civil emergency structure. And so, my lady, the inquiry will be looking at whether, as a nation, we were sufficiently resilient. Resilience is related to capacity and concerns the ability of a country to resist, absorb, and recover from shock. The ability to recover is closely connected to the general health and wealth of the country as a whole. It is for this reason that part of the module, as well as later modules in your inquiry, which will focus specifically on inequalities, will explore what state the nation was in as we entered the pandemic. Did the high levels of heart disease, diabetes, respiratory illness, and obesity render us more vulnerable? Had there been a slowdown in health improvement in the decade before? Had health inequalities widened? Did emergency planning sufficiently account for pre-existing health and societal inequalities, deprivation, structural racism, and other forms of discrimination which undoubtedly exist in society? As for wealth, it is self-evident that the capacity of any country's public health care and social care systems to be able to cope with the pandemic is constrained by funding, and therefore you need to inquire how well funded were the United Kingdom's health structures, to what degree have our public services, especially those of health and social care, suffered from underinvestment, how well resourced were the United Kingdom's public health structures. My lady, these questions must be asked. This is not because it lies in the power of your inquiry to resolve them. The inquiry plainly cannot of itself bring about general improvements in health, social care or public services, let alone direct that they be made. The questions must be asked because I have no doubt that if you conclude that as a country we were insufficiently resilient and that in future different political and financial choices may have to be made in order to render us better able to withstand a system shock, you will want to say so. But the need for all these questions is obvious. First, the bereaved and those who otherwise suffered, of whom there are very many in number, are entitled to know if anything could have been done to prevent their loss or reduce their suffering. Second, if we were shocked by the outbreak of COVID-19, history suggests we should not have been. Epidemics, that is to say the occurrence of a disease in a population at a level that is significantly above the baseline level, occur frequently. They can come on extraordinarily rapidly and spread very quickly. They kill large numbers of people. Pandemics, whilst rarer, are not new. Ever since humans have walked on this earth, pandemic disease, the Black Death, plague, cholera, typhoid, yellow fever, influenza, and Ebola has walked with us. And scientists are clear that there is an ever-increasing risk of pandemics in the future. Diseases from animals, zoonotic diseases, pose a perpetual threat. A large proportion of those viruses which infect mammals are capable of infecting humans, and many of them have been associated with human deaths. At the same time, diseases are becoming more prevalent and are being spread wider and faster on account of globalization and urbanization. So it's vital that international surveillance and alert systems work effectively. Furthermore, terrible though it is to acknowledge, the rate in the United Kingdom at which COVID-19 generally killed those persons who were confirmed to have been infected with it, the case fatality rate, was relatively low, around 1%. The 1918 H1N1 flu pandemic was worse. Its case fatality rate was around 2.5% to 6%, and it caused a massive number of deaths worldwide. The estimates of death ranged in that pandemic from 17.5 million to 100 million. The case fatality rates of other diseases such as variant Creutzfeldt-Jakob disease, Ebola and smallpox were also much higher than SARS-CoV-2. Significantly, the case fatality rate of MERS, the Middle East Respiratory Syndrome coronavirus, the disease from camels that erupted in 2012 in the Kingdom of Saudi Arabia, was about 34.3%. SARS, severe acute respiratory syndrome, CoV-1, the earlier coronavirus pandemic in 2002, was around 9.6%. The relatively mild swine flu in 2009 to 10, about which we'll hear a considerable amount of evidence in due course, was less than 0.01%. What is critical, therefore, is transmissibility. The more infectious the disease is, the more people are infected and the greater number of people that will die. So the disease which poses the greatest risk to human life is the one that is both highly infectious or transmissible and once transmitted, severe or deadly. And at the moment, there are two notable subtypes of avian influenza or bird flu that are prevalent. Both have extremely high case fatality rates. Fortuitously, they haven't yet sustained human-to-human transmission. Let us hope they never do. But the possibility cannot be ruled out, which of course adds an even greater impetus for the need to ensure that our systems of preparedness are ready. My lady, the module is ambitious in terms of its scope. The documentary material which it encompasses is vast, but there's a limit. And I need to make plain what those limits are. First, Module 1 is not an inquiry into all aspects of the United Kingdom's emergency planning systems. It's only an inquiry into those parts of the general structures as is necessary to enable you to answer the questions: were the structures and systems ready for the pandemic that struck, and how can we make them better ready for next time? Secondly, Module 1 has a time frame, and I've already referred to the second date, the end date, the 21st of January 2020, when the Situation Report 1 was issued by the World Health Organization. It is beyond the ability of your inquiry to go back before June 2009, which was when the World Health Organization announced that scientific criteria for an influenza pandemic had been met for what became known as the 2009 swine flu pandemic. A third important point is that the inquiry needs to be aware of the difference between structure, central government departments, regional government, devolved administrations and the like; policy, which is government departments and bodies setting out rules as to how they'll go about deciding what to do; the planning, what is everyone meant to do; and finally, operational response, how services and help are actually provided. They are all important, but operational response is not a matter for Module 1. Equally, issues such as the core political and administrative decision-making, the merits and the timings of national lockdowns, vaccines, the specifics of healthcare, the response of the care sector, the detail of test and trace, PPE procurement, financial assistance, the government's response, and the impact of the pandemic on various sectors of the country, particularly including the vulnerable, are for later modules. The more detailed exploration of the way in which the country responded has to await those later modules. May I now then turn to the system for preparedness. It is obvious, my lady, that the degree to which COVID-19 could be prevented from laying waste to society was a matter within the control of government and the systems for EPRR which existed. Those systems may not be able to stop a pandemic in its tracks, but they ought to be able to put in place measures of understanding a virus, understanding and forecasting how it might develop, tracking it, limiting transmission, and coping with the consequences of large-scale transmission. In order to see what worked well and what faltered or failed, I'm afraid it's necessary to have a basic level of understanding of how the systems were set up. Many following this opening statement may have some appreciation of the terms and of the bodies of the structures, but for those who do not, it's necessary to set out some short definitions and explanations which will assist in their understanding of the evidence which you will shortly hear. My lady, it is a particularly complicated system. To help us guide listeners through it, could we have, please, on the screen a document prepared by the inquiry, INQ 204014. My lady, this is a document which the inquiry team have prepared, which sets out the basic structures concerning EPRR for the United Kingdom and England, and also for Scotland, Wales and Northern Ireland. The INQ number is just a reference to the inquiry's electronic document system. I should say that this is a document which is evolving. We will improve it as we go along in light of helpful comments from core participants and the various government and devolved administrations in the United Kingdom. Could we go forward, please, to page 4? That, my lady, is a schematic representation of the United Kingdom and England's emergency preparedness, response and resilience system. Starting from the top, the Cabinet Office, of whom, of course, we've heard much in recent days, is the government department in the United Kingdom responsible for supporting the Prime Minister and the Cabinet. It is composed of various units that support Cabinet committees and which coordinate the delivery of government objectives, but primarily working with other government departments. One of its most important functions is national security and the coordination of the United Kingdom government's response to crises. My lady, it's obvious that in an emergency, the Cabinet Office needs to draw on the expertise of other government departments in its emergency planning. And so there is something called the lead government department. In relation to a pandemic, it's obvious that the lead government department would be the Department of Health and Social Security. And we can see in the middle of the screen, and I emphasise, just for convenience sake, we're focusing on the United Kingdom and England in this schematic design, rather than looking at Scotland, Wales and Northern Ireland, for which there are equally schematic designs of no less importance. So the blue part in the middle of the picture represents the Department for Health and Social Care. Lead government departments are the government departments which are appointed to deal and lead on issues which concern and affect them most. So, my lady, one of the questions which you'll be addressing is whether or not this lead government department model the correct one for a whole system civil emergency, or do the requirements of this acute type of crisis require a different approach? If so, what approach should that be? It is self-evident that in a crisis of the magnitude of the COVID-19 pandemic, the burden could not solely be carried by the lead government department, because, of course, the pandemic affected every part of the government and of British public life, from education to the care sector, of course, to the Treasury, to our finances, our jobs and livelihood. The Department for Health and Social Care oversees the National Health Service in England. It oversees the United Kingdom's arm-length bodies, such as the United Kingdom Health Security Agency. So a primary question going into the pandemic was the Department of Health and Social Security adequately prepared? Did it identify with sufficient adequacy the surge capacity in terms of hospital infrastructure, clinicians and support workers that would be required? During the Module 1 timeframe, the Civil Contingency Secretariat was the Cabinet Office unit that managed both the United Kingdom government's preparedness for and its response to major nationwide emergencies. My lady, it was established in 2001, and in July 2022, after the pandemic, was split into two separate functions, focusing on its emergency response functions, the COBRA unit, about which we'll hear a great deal more, and resilience frameworks, called the Resilience Directorate. And thank you very much. The Civil Contingency Secretariat has been highlighted at the top of the screen. Towards the top right of the screen, you will see a reference to the National Security Risk Assessment. The National Security Risk Assessment is the United Kingdom government's classified assessment of the top national level risks facing the United Kingdom. The assessment focuses on both the likelihood of the risk occurring and the impact it would have were it to happen. And it has a public-facing document, the National Risk Register, which provides information for those who have formal contingency planning responsibilities at a national, regional and local level. But indeed, we know, of course, what the broad nature of future emergencies might be. Natural hazards include global health challenges, animal and plant diseases, growing antimicrobial resistance, space weather events, extreme weather, climate change, infrastructure collapse, or perhaps the unintended consequence of human endeavour and artificial intelligence. The world is an uncertain place, and risks seem set only to grow. The exact nature of those major risks cannot, of course, be identified in advance. And because it's not possible to know in advance with certainty which risks will crystallise and how, and because it's not practical to plan for every major risk, there will always be uncertainty. So the government draws up policies, and those policies are by their nature of more general application. But both the policies and the planned operational responses must build in the ability to respond to the unknown and provide for contingencies. Government planning must be flexible. Were the governments of the 4 countries flexible enough with their policy making? Was the consideration of what those risks might be and how they could be prepared for sufficiently imaginative? My lady, you will hear evidence that for many years an influenza pandemic was assessed as being one of the most likely risks to the United Kingdom. But what about other risks that, whilst they might be less likely, could be just as, if not more deadly? Did planning sufficiently address the risk not only of the known, but the unknown? A new pathogen, a new disease, a disease X, as it's known, with pandemic potential. Did planners pay sufficient focus on potential impact as opposed to likelihood? With COVID, the evidence will demonstrate that the government thought that the greater risk was an influenza pandemic and therefore devoted more time and resources to that possibility. In the event, we were hit, of course, by a coronavirus. That might suggest a lack of flexibility or proper foresight. Or perhaps the policies, plans and structures were so flexible and broad, so as to cover any reasonable possibility, that this prevented us from focusing enough upon those particular risks which, as I say, whilst being perhaps less likely, could cause us more harm. So a core question in Module 1 will be, to what extent was thought given to and planning devoted to the risk of a new emerging infectious disease that was not influenza? Did the system of planning become self-validating or complacent so that that question was not asked, or if it was asked by individuals, was not listened to? To what extent were the likely consequences of either influenza or a new and emerging infectious disease reassessed? My lady, the evidence may show that there was a degree of assumption in the process that if there was to be an influenza pandemic, it would be bound to lead to hundreds of thousands of deaths. This was because planners positively planned on what was known as the reasonable worst-case scenario, the RWCS, planning for the worst case that could realistically happen. The good sense of planning for the worst case that could realistically happen is obvious. You need to prepare everyone to respond to that possibility, to have enough resources, enough